Good morning. My name is Zhong-Lin. The title of my presentation is The Contrast Sensitivity Function from Laboratory to Clinic. Before I start, I would like to thank Philip, Mark, and Jay for organizing the symposium and inviting me to give this talk. I also need to disclose that I'm a co-founder of Adaptive Sensory Technology and have patent and personal financial interest in the company. The contrast sensitivity function provides a comprehensive description of spatial vision. The graph in this slide shows an example. Here, the spatial frequency of the background grading increases from left to right, which its contrast decreases from bottom to top. The contrast sensitivity function divides the two-dimensional space into two regions, a visible region under the white curve and the invisible region above it. We need more contrast to see patterns in low and high spatial frequencies, and less contrast to see objects in intermediate spatial frequencies. The contrast sensitivity function describes visual sensitivity in many species and is correlated with performance in daily living activities. Many patients have normal letter acuity or perimetry, but contrast sensitivity deficits. In the clinic, contrast sensitivity deficits have been observed in patients with age-related macular degeneration, or AMD, diabetes, cataract, glaucoma, and treated amblyopia. In this case, patients with recovered visual acuity still have large contrast sensitivity deficits. For people with elite vision, such as baseball players, the contrast sensitivity is much better than normal. You may want to ask, if contrast sensitivity function is so good, why doesn't everybody use it? The answer is a prohibitive test time. To measure a single contrast sensitivity function requires measurement of contrast thresholds of 5 to 6 spatial frequencies, with a minimum of 30 to 50 trials per spatial frequency. This usually takes about 200 to 300 trials, or 20 to 30 minutes per eye per test condition. For this reason, a number of shortcuts have been developed to estimate contrast sensitivity in the clinic, including the Petty-Robson and Mars letter charts that measure contrast sensitivity at a single letter size or single spatial frequency, and vector vision and fact grading charts that measure contrast sensitivity at a number of spatial frequencies. However, the letter charts sacrifice spatial frequency resolution, and the grading charts sacrifice contrast resolution. In addition, the printed charts are limited in number and can be learned by the observer. They also abandon temporal frequency testing. When we overlay the sampling schemes of the charts on the two-dimensional spatial frequency and contrast space, it's obvious that the charts only provide a very coarse sampling of the space and cannot provide accurate nor precise assessment of the contrast sensitivity function. In fact, accurate and precise assessment of the contrast sensitivity function requires high-resolution sampling of the two-dimensional spatial frequency and contrast space. At the same time, we must keep the test short. This is why active learning algorithms are critical. The goal is to focus sampling to the critical regions of the two-dimensional space, namely the regions close to each individual contrast sensitivity function. As shown in this slide, the optimal sampling for normal CSF is quite different from that of a normal CSF. About 10 years ago, we developed a quick CSF method based on active learning algorithm. First, we characterized the contrast sensitivity function with a truncated log parabola with 4 parameters: peak sensitivity, peak spatial frequency, bandwidth, and low spatial frequency truncation. We then use an active learning algorithm to search a library of potential contrast test items, test with personalized, optimized items, analyze responses with a computational model, repeat until they converge on a base optimal test sequence. Here's a demo of the original quick CSF algorithm. The black curve is the true contrast sensitivity function of the simulated observer. The color maps show the distributions of the parameters of the CSF and the CSF itself. In each trial, the algorithm selects the optimal test stimulus, collects the simulated observer's response, and updates the posterior distributions. The blue dots indicate correct trials, and the red dots indicate incorrect trials. As the test goes on, the posterior distributions become narrower. In about 50 trials, the estimated CSF indicated by the green curve converges to the true contrast sensitivity function of the simulated observer. Here's the movie. The original quick CSF method was based on a two-interval forced-choice gradient detection task. We subsequently showed that increasing the number of alternatives in a forced-choice task can drastically improve test efficiency. In fact, the quick CSF method with a 10 letter identification task can estimate the CSF with a 0.1 log unit standard deviation in about 20 trials, or less than 2 minutes for a normal observer. Based on these results, we implement the quick CSF method with a 10 alternative forced choice letter identification task using filtered Sloan letters. Here's a new illustration of the contrast sensitivity function with bandpass filtered letters. From left to right, letter size decreases. From top to bottom, letter contrast increases. The contrast sensitivity function divides them into visible letters and invisible letters. We have also collaborated with Wu-Jie Kim, Mark Pitt, Mark Stivers, and Jie Myung to develop a hierarchical adaptive design optimization procedure to simultaneously classify a patient into disease categories and measure her contrast sensitivity function. Recently, we developed a hierarchical Bayesian data analytic framework to quantify the joint distributions of the parameters of the contrast sensitivity function at both individual subject and population levels across multiple conditions. We applied the framework to reanalyze the quick CSF data from 112 college-aged subjects tested in 3 luminance conditions. The parameters of the CSFs in the 3 luminance conditions were modeled with a 9-dimensional multivariate normal distribution at the population level and 3 3-dimensional multivariate normal distributions at the individual subject level. We were able to recover the joint distributions of the parameters of the contrast sensitivity function at both the individual subject and population levels across 3 luminance conditions. In this slide, I showed the covariance of the parameters of the contrast sensitivity function at the population level. The joint distributions significantly increase statistical power in a number of hypothesis tests. In the clinic, the quick CSF method can address the missed opportunity in vision testing. Currently, visual acuity tests only measure the smallest visible letter at the maximum contrast, and the contrast sensitivity test is performed only at a low spatial frequency. However, a lot of visual deficits occur in intermediate spatial frequencies. The quick CSF test can reveal large contrast deficits in size contrast conditions currently ignored in acuity and contrast sensitivity testing, and quantify functional loss and treatment effects that might otherwise be invisible to current testing. Since its invention in 2009, the quick CSF method has been adopted in many clinical studies over a number of visual dysfunctions. Here's one study conducted by John Miller at Mass Eye and Ear. In this study, John showed that the treatment signal for patients with retinal vein occlusion was very small, only 1.4 lines or 0.14 logMAR if it's measured with visual acuity. It's, however, enormous in terms of contrast sensitivity improvements. Here are some other highlights from quick CSF clinical studies. A 50% noise reduction relative to existing contrast tests. Hidden contrast sensitivity deficits in patients with good acuity. In diabetic macular edema, diabetic retinopathy, early or intermediate AMD, inherited retinal disease, central serous retinopathy, retinal detachment. Correlations with quality of life in multiple sclerosis with good acuity. Distinct recovery patterns of PRK and LASIK in low and high luminance following refractive surgery. Perceptual differences between contact lens designs that lead to different levels of visual satisfaction. A number of quick CSF clinical studies are still ongoing. We expect that the quick CSF method can continue to reveal hidden loss in vision and generate new clinical insights. To conclude, the contrast sensitivity function is an important outcome measure for basic and clinical vision science. The quick CSF method provides an accurate, precise, sensitive, and efficient assessment of the contrast sensitivity function. It can detect hidden vision loss in many visual dysfunctions. Its wide adoption in the clinic may facilitate the development of new treatments and improve clinical care. I would like to thank all my collaborators for their contributions to this project. I would also like to thank the funding agencies. Thank you very much for your attention.